Hello, dedicated future nurses. Welcome once again to Stancoast NCLEX, your trusted learning partner in mastering every concept that leads you to NCLEX success. We bring you 2 to 3 advanced NCLEX videos every single day, designed to build your confidence, deepen your clinical understanding, and prepare you to think like a professional nurse. Today's high-yield topic focuses on one of the most commonly tested and clinically significant respiratory conditions, chronic obstructive pulmonary disease, or COPD. In this session, we will explore the pathophysiology of chronic bronchitis and emphysema, the hallmark signs of hypoxia and hypercapnia, and the crucial nursing interventions that help clients breathe easier and live better. We will discuss oxygen therapy, positioning, breathing exercises like pursed lip breathing, and safe medication administration, including bronchodilators, corticosteroids, and mucolytics. You will also learn about nutrition, activity tolerance, and client education strategies that are essential both for exam success and for real-life nursing practice. So, stay tuned till the end, take notes, and engage fully, because every moment in this session takes you closer to mastering respiratory care. And always remember, at Stancoast NCLEX, we do not just prepare you to pass, we prepare you to care with precision, purpose, and passion. Let's begin this essential session on nursing care of clients with COPD.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash.
Let us smoothly transition into this insightful next question, which focuses on respiratory diagnostics and client education. Imagine a 68-year-old client with a 40-year history of smoking 2 packs per day who has now been diagnosed with emphysema. The healthcare provider schedules pulmonary function testing, commonly known as PFT, to assess the degree of airway obstruction and evaluate lung capacity. As the nurse reinforces pre-procedure teaching, the key question arises: which client statement best demonstrates an accurate understanding of the procedure? Now, here are the options to consider carefully. Option A, they will take a chest X-ray to see how much air my lungs can hold. Option B, a blood sample will be taken to check how well my lungs are working. Option C, I will have to blow in and out through a mouthpiece connected to a machine. Option D, they will collect some sputum from my lungs to measure my breathing ability. The correct answer is option C, stating, I will have to blow in and out through a mouthpiece connected to a machine. Moving into the detailed rationale, pulmonary function tests are non-invasive diagnostic assessments that quantify lung ventilation, diffusion, and volume capacities. The client performs a series of controlled breathing maneuvers, including deep inhalation, forceful exhalation, and sustained breathing, into a calibrated spirometer or pneumotachograph via a mouthpiece. This device is connected to a computerized system that measures airflow rates, total lung capacity, and lung compliance. The resulting spirogram helps clinicians analyze critical values such as forced vital capacity, FVC, forced expiratory volume in 1 second, FEV1, and the FEV1/FVC ratio. These values are essential in distinguishing obstructive diseases like chronic obstructive pulmonary disease and emphysema from restrictive lung disorders. Clients with emphysema typically show an increased total lung capacity and residual volume due to air trapping, but significantly reduced FEV1 and FEV1/FVC ratios, reflecting impaired exhalation. Before the test, clients must avoid smoking, bronchodilators, and heavy meals for several hours, as these factors can alter results. The test itself is painless, safe, and requires full cooperation for accurate data collection. Transitioning to the incorrect options for deeper understanding, option A, they will take a chest X-ray to see how much air my lungs can hold, is incorrect because a chest X-ray only provides visual information about structural changes like hyperinflation, a flattened diaphragm, or bully, but it cannot measure airflow or lung volume quantitatively. Next, option B, a blood sample will be taken to check how well my lungs are working, is also incorrect since an arterial blood gas test evaluates oxygen and carbon dioxide levels along with acid-base balance, but it does not measure airflow resistance or lung capacity. It complements but does not replace pulmonary function testing. Finally, option D, they will collect some sputum from my lungs to measure my breathing ability, is incorrect, because sputum analysis is designed to detect pathogens or abnormal cells in infections or cancer, not to determine breathing function or airflow limitation. And now, before we conclude, let us highlight the Stancoast Clinical Insight, which states, pulmonary function testing transforms breathing into measurable data. It is the bridge between a client's symptoms and the objective reality of how air moves through their lungs, a vital tool for tailoring therapy in chronic respiratory diseases. Finally, here comes the Stancoast High-Yield NCLEX Pearl. Before performing PFTS, nurses should instruct clients to avoid smoking and bronchodilators for 4 to 6 hours, remain seated upright during testing, and exert maximal effort in each breath to ensure accurate results. After testing, observe for dizziness or shortness of breath, as mild hyperventilation can occur. This question beautifully integrates client education, physiology, and nursing reasoning. A perfect blend for NCLEX mastery. Let us smoothly transition into this next advanced level NCLEX-style question that focuses on respiratory assessment and the interpretation of arterial blood gases. Imagine a 67-year-old client with a long-standing history of chronic obstructive pulmonary disease who is admitted with worsening shortness of breath and a productive cough. The healthcare provider orders an arterial blood gas analysis to evaluate the client's respiratory function. The results reveal that the partial pressure of arterial carbon dioxide, or PaCO2, is 65 millimeters of mercury. Now, the nurse must determine why this finding is abnormal by recalling the normal range for PaCO2. Here are the options to consider carefully. Option 1, 7.35 and 7.45. Option 2, 80 and 100 millimeters of mercury. Option 3, 35 and 45 millimeters of mercury. Option 4, 22 and 26 millimeters of mercury. The correct answer is option 3, 35 and 45 millimeters of mercury. Moving forward to the detailed rationale, arterial blood gas analysis is a vital diagnostic tool that helps evaluate acid-base balance and gas exchange efficiency in the body. It measures key parameters such as pH, partial pressure of oxygen, partial pressure of carbon dioxide, and bicarbonate. The normal PaCO2 range is between 35 and 45 millimeters of mercury, which reflects the concentration of carbon dioxide dissolved in arterial blood, a direct marker of how effectively the lungs are ventilating. When PaCO2 rises to 65 millimeters of mercury, it indicates hypoventilation and carbon dioxide retention, which are hallmarks of respiratory acidosis often seen in chronic obstructive pulmonary disease and other hypoventilatory disorders. In such clients, airway obstruction and air trapping prevent adequate exhalation, leading to the accumulation of carbon dioxide in the bloodstream. This elevated level signals poor alveolar ventilation, requiring immediate nursing interventions such as bronchodilator administration, controlled oxygen therapy, and breathing exercises like pursed lip breathing to enhance carbon dioxide elimination. To clarify, a pH range of 7.35 to 7.45 represents normal acid-base balance. The partial pressure of oxygen, or PaO2, should range between 80 and 100 millimeters of mercury, reflecting adequate oxygenation. Bicarbonate levels of 22 to 26 milliequivalents per liter indicate proper metabolic balance regulated by the kidneys. Therefore, knowing each of these normal values enables the nurse to distinguish whether an imbalance is respiratory or metabolic, acute or chronic, and whether the body is compensating effectively. Now, transitioning into Stancoast Clinical Insight. Each arterial blood gas value is like a window into the lung's performance. When PaCO2 rises, it tells the story of trapped air and failing ventilation, reminding nurses that every breath counts in chronic lung disease. Finally, to wrap up with a quick summary, Stancoast High-Yield NCLEX Pearl. Normal PaCO2 ranges between 35 and 45 millimeters of mercury. An elevated PaCO2 indicates respiratory acidosis, commonly seen in chronic obstructive pulmonary disease or respiratory failure, while a low PaCO2 suggests respiratory alkalosis, as in hyperventilation or anxiety. Always interpret PaCO2 values in conjunction with pH and bicarbonate to identify the primary disturbance and the body's compensatory mechanism. Let us now move ahead into another advanced level NCLEX-style question that focuses on oxygen administration and respiratory physiology. Picture this scenario carefully. A 68-year-old client with a long-standing history of chronic obstructive pulmonary disease is admitted to the hospital due to an acute exacerbation. The client presents with increased dyspnea, productive cough, and hypoxemia. Arterial blood gas analysis shows a pH of 7.33, a partial pressure of arterial carbon dioxide at 58 millimeters of mercury, and a partial pressure of arterial oxygen at 55 millimeters of mercury. The healthcare provider prescribes supplemental oxygen, and the nurse prepares to administer it using a nasal cannula. Now comes the critical thinking moment. Which oxygen flow rate should the nurse select to safely improve oxygenation without suppressing the client's respiratory drive? Here are the options to analyze carefully. Option 1, 2 liters per minute. Option 2, 5 liters per minute. Option 3, 8 liters per minute. Option 4, 10 liters per minute. The correct answer is Option 1, 2 liters per minute. Moving forward to the in-depth rationale, clients with chronic obstructive pulmonary disease retain carbon dioxide due to long-term alveolar damage and loss of lung elasticity. Over time, their central chemoreceptors, which normally respond to high carbon dioxide levels, become desensitized. Consequently, their body relies on peripheral chemoreceptors that sense low oxygen levels to trigger breathing, a mechanism known as the hypoxic drive. Administering high-flow oxygen can abruptly increase the arterial oxygen level, thereby eliminating the stimulus and potentially causing respiratory depression or apnea. For this reason, oxygen must be delivered at low flow rates of 1 to 2 liters per minute via nasal cannula, maintaining oxygen saturation between 88 and 92% while preventing carbon dioxide retention. Continuous pulse oximetry and regular arterial blood gas monitoring are vital to ensure safety and appropriate adjustment. If hypoxemia persists, escalation to a Venturi mask at 24 to 28% oxygen concentration may be necessary. Nurses should also watch for carbon dioxide narcosis, which manifests as confusion, drowsiness, and reduced respiratory rate. Transitioning into the explanation for the incorrect choices, Option 2, which is 5 liters per minute, delivers approximately 40% oxygen concentration, too high for chronic carbon dioxide retainers. This could suppress the hypoxic drive, leading to hypoventilation and potentially life-threatening respiratory acidosis. Meanwhile, Option 3, 8 liters per minute, delivers about 60% oxygen concentration, which risks oxygen-induced hypercapnia and altered mental status. Finally, Option 4, 10 liters per minute, exceeds 70% oxygen concentration and is appropriate only for emergencies or short-term use with a non-rebreather mask, never for clients with chronic respiratory diseases like COPD. Transitioning to the Stancoast Clinical Insight. Every liter of oxygen carries responsibility. For the COPD client, more is not better. Precision saves the breath that sustains life. And now for the Stancoast High-Yield NCLEX Pearl. Maintain oxygen flow between 1 and 2 liters per minute via nasal cannula in chronic carbon dioxide retainers. Target oxygen saturation between 88 and 92%, not 100%. Continuously monitor for carbon dioxide narcosis, confusion, headache, and shallow breathing, and always document the oxygen delivery device, flow rate, and client response accurately.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us transition smoothly into another advanced level NCLEX style question that highlights the nurse's understanding of respiratory pharmacology and clinical reasoning. During the management of a client experiencing an acute episode of chronic bronchitis, the nurse prepares to administer intravenous aminophylline, also known as trufilline, as prescribed. The client's arterial blood gas analysis reveals mild respiratory acidosis and hypoxemia. Now, here comes the critical question for you to consider. What is the primary rationale for administering aminophylline in this clinical situation? Here are the options for you to evaluate carefully. Option 1, to relieve persistent coughing. Option 2, to reduce sputum production. Option 3, to dilate the bronchial airways. And Option 4, to thin respiratory secretions. The correct answer is Option 3, to dilate the bronchial airways. Now, moving into the expanded rationale to strengthen your understanding. Aminophylline, a derivative of theophylline, belongs to the methylxanthine class of bronchodilators. Its primary therapeutic action involves relaxing the smooth muscles of the bronchi and pulmonary blood vessels, which leads to enhanced airflow and improved oxygenation. Mechanistically, aminophylline functions through phosphodiesterase inhibition, resulting in elevated intracellular cyclic adenosine monophosphate (CAMP) levels. The rise in CAMP causes smooth muscle relaxation and bronchodilation, which significantly reduces airway resistance and improves gas exchange, especially in clients with chronic obstructive airway conditions such as asthma, chronic bronchitis, and chronic obstructive pulmonary disease. Another vital aspect of aminophylline's action is its stimulation of the medullary respiratory center, thereby increasing the drive to breathe, an essential effect in individuals with chronic carbon dioxide retention. In clinical practice, this bronchodilating effect translates to eased breathing, reduced wheezing, and improved oxygen saturation levels, which altogether relieve respiratory distress. However, it is important to note that aminophylline does not directly suppress coughing, decrease mucus production, or thin secretions. Those effects are generally achieved with expectorants, mucolytics, or adequate hydration, not bronchodilators like aminophylline. Furthermore, nurses must be vigilant because aminophylline has a narrow therapeutic index, typically between 10 to 20 micrograms per milliliter. Frequent monitoring of serum drug levels is essential to prevent toxicity. Warning signs of toxicity include nausea, vomiting, restlessness, tachycardia, and even seizures. The drug should be used cautiously in clients with liver impairment or cardiac dysrhythmias, since reduced metabolism can increase serum levels. Also, be mindful of potential drug-drug interactions. Agents such as ciprofloxacin, cimetidine, and erythromycin can increase aminophylline levels, whereas phenytoin and barbiturates can reduce its effectiveness. Transitioning to the Stancoast clinical insight. Before we wrap up this question, here's an important reflection. Bronchodilation is the breath between distress and relief. Aminophylline restores that space, relaxing airway smooth muscles, enhancing airflow, and helping the lungs reclaim their rhythm of life. And now for the Stancoast High-Yield NCLEX Pearl. To summarize key exam takeaways, aminophylline works as a phosphodiesterase inhibitor, increasing CAMP to promote bronchial smooth muscle relaxation. Maintain its serum levels between 10 and 20 micrograms per milliliter and monitor for toxicity signs such as nausea, tachycardia, dysrhythmias, restlessness, and seizures. Caffeine should be avoided since it enhances central nervous system and cardiac stimulation. Most importantly, ensure continuous cardiorespiratory monitoring and educate clients to report palpitations or tremors immediately. Let us now move into another clinically significant pharmacology scenario that highlights the nurse's vigilance in identifying early adverse effects during therapy. A nurse is closely monitoring a client who has been prescribed intravenous aminophylline, also known as trufilline, for the management of acute bronchospasm secondary to chronic obstructive pulmonary disease. During the infusion, the nurse notices that the client begins to experience palpitations and a mild sense of restlessness. Now, here's the question to consider carefully. Which adverse effect is most consistent with the pharmacological action of aminophylline? Here are your options to reflect on. Option A, bronchospasm. Option B, hypotension. Option C, drowsiness. And Option D, tachycardia. The correct answer is Option D, tachycardia. Now, let us unfold the rationale behind this answer in depth. Aminophylline, a methylxanthine derivative of theophylline, works primarily by inhibiting the enzyme phosphodiesterase, which leads to an increase in intracellular cyclic adenosine monophosphate, CAMP. This elevation in CAMP relaxes bronchial smooth muscles, resulting in bronchodilation, improved airflow, and reduced airway resistance. However, along with these beneficial effects, aminophylline also stimulates the sympathetic nervous system and enhances the release of catecholamines. This dual action increases cardiac excitability and central nervous system activity, producing tachycardia, a predictable and dose-dependent response. Clinically, this may appear as palpitations, nervousness, or even mild hypertension. When serum levels rise above the therapeutic range of 10 to 20 micrograms per milliliter, the drug can cross into toxic levels, causing severe cardiac arrhythmias, hypotension, or seizures. This is why nurses must vigilantly monitor plasma levels and titrate the dose carefully to prevent toxicity. Moving on, let us evaluate why the other options are incorrect. Option A, bronchospasm, is incorrect because aminophylline actually prevents bronchospasm by promoting bronchodilation through smooth muscle relaxation. Its therapeutic purpose directly contradicts this option. Option B, hypotension, is also not typical. While transient hypotension can occur if the drug is infused too rapidly, the primary cardiovascular response is tachycardia and sometimes mild hypertension due to adrenergic stimulation. Option C, drowsiness, does not fit because aminophylline is a central nervous system stimulant. Instead of sedation, clients often report restlessness, insomnia, or anxiety. Now, before we wrap up, let us connect this with a deeper perspective through the Stancoast clinical insight. Each breath that returns after aminophylline therapy is a reminder that precision matters. The same mechanism that opens the bronchi can race the heart. Nursing vigilance transforms this dual edge of therapy into safe, controlled relief. And finally, as we conclude this concept, let us emphasize the key takeaway with the Stancoast High-Yield NCLEX Pearl. Always remember, the therapeutic range of aminophylline is 10 to 20 micrograms per milliliter, and toxicity usually starts above 20. Watch for early warning signs such as restlessness, nausea, tremors, and palpitations. Nursing priorities include close monitoring of serum levels and cardiac rhythm, avoiding caffeine to reduce additive stimulation, and promptly reporting any signs of toxicity like severe palpitations or chest pain. Let us now transition smoothly into this advanced NCLEX-style question that challenges your understanding of respiratory interventions and clinical reasoning. A nurse is performing postural drainage for a client diagnosed with chronic bronchitis. The goal is to facilitate the removal of thick pulmonary secretions and improve airway clearance. Now, let us explore which nursing intervention should be performed during this important procedure. The options are as follows. Option A, encourage the client to take slow, deep breaths. Option B, perform rhythmic clapping over the chest using cupped hands. Option C, apply firm pressure beneath the diaphragm during exhalation. And option D, place the client in an upright sitting position throughout the procedure. The correct answer is option B, perform rhythmic clapping over the chest using cupped hands. Moving forward into the rationale, rhythmic clapping or percussion using cupped hands is a cornerstone of airway clearance therapy. This technique creates mechanical vibrations that help loosen and mobilize thick mucus from the bronchial walls toward the larger airways, where it can be effectively coughed out. The cupped shape of the hands forms a small pocket of air between the palm and chest wall, which cushions the impact and prevents tissue trauma. This rhythmic percussion is performed over each lung segment for several minutes, avoiding areas such as the spine, sternum, and ribs. When paired with vibration and deep breathing exercises, this method significantly enhances secretion clearance and promotes effective coughing. Furthermore, the therapeutic purpose of this intervention is to improve oxygenation, enhance ventilation perfusion balance, and prevent complications such as atelectasis or infection resulting from secretion retention. Ideally, postural drainage is conducted before meals, or 1 to 2 hours after eating to reduce the risk of nausea or aspiration. Nurses should also administer bronchodilators or mucolytics prior to the session to relax airways and thin secretions, optimizing the overall effectiveness of treatment. Now, let us take a moment to analyze why the remaining options are incorrect. Beginning with option A, encouraging the client to take slow, deep breaths helps expand the lungs and promote oxygen exchange. but it does not physically loosen mucus. It only supports ventilation. Moving to option C, applying firm pressure beneath the diaphragm during exhalation is a manual-assisted cough technique, used primarily for clients with weak cough reflexes, such as those with spinal cord injuries, not for secretion mobilization during postural drainage. Finally, option D, placing the client in an upright sitting position, may assist ventilation but defeats the purpose of gravity-assisted drainage. Effective postural drainage relies on positioning the client so that the specific lung segment being drained is elevated above the trachea, allowing gravity to direct secretions towards central airways for expulsion. Now, let us connect this understanding to real clinical practice through the Stancoast clinical insight. Postural drainage transforms gravity into therapy. When combined with percussion and vibration, it empowers the lungs to clear what medication cannot, making each clap a step toward cleaner airways and better oxygenation. Before we wrap up, remember this key NCLEX takeaway through the Stancoast High-Yield NCLEX Pearl. The main purpose of postural drainage is to mobilize and drain thick bronchial secretions using gravity and percussion. The correct technique involves using cupped hands for percussion while avoiding bony areas or breast tissue. Timing is also crucial. It should be performed before meals or 1 to 2 hours after eating to prevent aspiration. Additionally, bronchodilators or mucolytics should be administered beforehand to maximize secretion clearance. Lastly, always stop the procedure immediately if the client experiences dyspnea, chest pain, or dizziness. Yo, future RN, hold up just for a second. Before we dive in, let me put you onto something that's blowing up among nursing students. The ultimate NCLEX crash course. Over 100,000 students have already passed with it because it's not just a course, it's your total NCLEX game plan. You'll get live and recorded classes, 5,000 killer practice questions, 30 full tests, PDFs, planners, and detailed NGN tutorials. You're getting everything you need, no fluff, no confusion, just results. So go ahead. Scan that QR code or click the link right now to join and grab your free notes, quizzes, and Telegram WhatsApp access before they're gone. Let us now move into this engaging NCLEX-style clinical reasoning scenario that highlights a key respiratory intervention. A nurse is evaluating the effectiveness of postural drainage in a client with chronic bronchitis. The question to consider is, which nursing observation provides the best evidence that the procedure has been effective? The available options are as follows. Option A says the client's respiratory rate is increased. Option B states the client's heart rate is much improved. Option C mentions the client's sputum culture is negative. And option D indicates the client raises a large volume of sputum. The correct answer here is option D. The client raises a large volume of sputum. Now, let us explore the detailed reasoning behind this answer. The most reliable evidence that postural drainage has been effective is when the client expectorates a large volume of sputum immediately after the procedure. Postural drainage works by using gravity-assisted positioning and rhythmic manual percussion to move mucus from the smaller bronchioles up into the larger airways, allowing it to be coughed out more easily. The ultimate goal is not merely to improve the vital signs, but to enhance airway clearance by physically eliminating retained secretions that block airflow and impair gas exchange. When mucus plugs are loosened and expelled, alveolar ventilation improves, oxygenation increases, and the client's breathing effort gradually decreases. Furthermore, producing an increased volume of sputum after therapy directly confirms that mucociliary transport and mechanical drainage have been successful. As these secretions are cleared, breath sounds often evolve from coarse crackles to clearer lung fields, and oxygen saturation rises steadily. Over time, this improvement results in better lung compliance, decreased airway resistance, and overall respiratory comfort. Moving on to why the other options are not correct, let us first discuss option A. The client's respiratory rate is increased. An elevated respiratory rate usually reflects ongoing respiratory distress or hypoxia rather than improvement. In fact, once postural drainage has been successful, the respiratory rate should normalize as oxygenation improves. Next, consider option B. The client's heart rate is much improved. Although heart rate may decrease slightly with better oxygenation, it is not a direct or specific indicator of airway clearance. Cardiac improvement alone cannot verify mucus removal. Finally, for option C, the client's sputum culture is negative. This finding only indicates the absence of infection, not that mucus clearance occurred. Postural drainage is a mechanical procedure that facilitates secretion removal, not an antimicrobial intervention, so culture results are unrelated to its effectiveness. Transitioning now to the key learning takeaway, here is the Stancoast clinical insight. Postural drainage success is not measured in vital signs, but in visibility. The sight of mobilized sputum means gravity and technique work together to open the airways and restore airflow. And before we conclude, let us highlight the Stancoast high-yield NCLEX Pearl. Purpose: mobilize and clear bronchial secretions using gravity-assisted drainage and percussion. Outcome indicator: raise sputum volume and improve lung sounds following the procedure. Stop if the client reports chest pain, severe dyspnea, or dizziness. Best timing: perform the procedure before meals or 1 to 2 hours afterward to prevent nausea or aspiration. Pre-procedure tip: administer bronchodilators or mucolytics beforehand to relax the airways and thin mucus for optimal drainage. Let us now move to another high-yield respiratory care scenario that tests both your knowledge and attention to detail. Imagine a nurse teaching a client newly diagnosed with asthma how to correctly use a metered dose inhaler containing albuterol sulfate, also known as Ventolin. After administering the first puff, the nurse observes the client's actions to determine if the inhaler is being used properly. The question to consider is, after the first puff, which action best demonstrates correct technique and ensures optimal medication delivery? Here are the available options to think through carefully. Option 1 states that the client immediately depresses the canister again before exhaling. Option 2 says the client holds their breath for about 10 seconds before exhaling slowly. Option 3 suggests the client wipes the mouthpiece with a dry paper tissue after use. Option 4 indicates the client bends forward at the waist to increase exhaled volume. The correct answer is option 2. The client holds their breath for about 10 seconds before exhaling slowly. Now, let us explore the expanded rationale behind this response. Albuterol sulfate, commonly recognized by the brand name Ventolin, is a short-acting beta-2 adrenergic agonist, SABA, designed to relax bronchial smooth muscle and quickly relieve acute bronchospasm by stimulating beta-2 receptors in the airway. To achieve full therapeutic benefit, the client must coordinate inhalation, breath holding, and exhalation in the right sequence. Holding the breath for approximately 10 seconds after inhalation allows the aerosolized medication to settle deep within the bronchioles and alveoli, ensuring effective absorption at the target site. If the client exhales immediately, most of the medication would be expelled before reaching the lower airways, resulting in suboptimal relief. Slow exhalation through pursed lips afterward helps maintain airway pressure, promoting bronchiolar stability and improved oxygen exchange. If the client is prescribed 2 puffs, it is essential to wait about 1 to 2 minutes before taking the next dose. This pause allows the first puff to open the airways, ensuring the second puff penetrates more deeply into the lungs. It is equally important to clean the mouthpiece daily using warm running water and allow it to air dry completely. Wiping it with a dry tissue alone is insufficient, as residue buildup can block medication flow. Before each use, the client should also shake the inhaler thoroughly to ensure even distribution of the drug particles. In the bigger picture, correct inhaler use is one of the most vital self-management skills in asthma care. Improper technique remains one of the top reasons for poor symptom control, frequent exacerbations, and avoidable hospital visits. Therefore, nurses must reinforce the correct sequence at every teaching opportunity. Shake, exhale fully, seal lips around the mouthpiece, press and inhale deeply. Hold the breath for 10 seconds. Exhale slowly, and then wait 1 to 2 minutes before repeating if another puff is ordered. Moving forward to a deeper Stancoast clinical insight. Each breath with an inhaler is not just inhalation, it is precision. A 10-second pause transforms a simple puff into a life-saving breath by ensuring that every particle reaches the bronchioles where it truly matters. Transitioning now to the Stancoast high-yield NCLEX Pearl. Medication class: short-acting beta. 2 agonist SABA, providing rapid bronchodilation during acute asthma episodes. Technique: priority: inhale slowly and deeply. Hold the breath for about 10 seconds, then exhale gradually. Timing: between puffs, wait 1 to 2 minutes between doses for better absorption. Maintenance. Tip: clean the mouthpiece daily with warm water and let it air dry. Safety alert: Overuse may lead to tachycardia, tremors, or hypokalemia, so clients should promptly report increased reliance on their rescue inhaler to the healthcare provider. Shifting our focus to another insightful NCLEX-style communication scenario, let us consider a 68-year-old client diagnosed with advanced emphysema who expresses deep frustration before discharge, saying, "This disease makes me a prisoner in my own home. I cannot do anything anymore." The key question here is, which nursing response best demonstrates therapeutic communication and supports emotional adjustment to chronic illness? Here are the available options to examine thoughtfully. Option 1. Tell me more about how you are feeling. Option 2. There are lots of things you can still do. Option 3. You are just having a bad day today. Option 4. What makes you say that? The correct answer is Option 1. Tell me more about how you are feeling. Delving into the expanded rationale, this question evaluates the nurse's ability to apply therapeutic communication techniques that build empathy, trust, and emotional openness. Clients living with chronic obstructive pulmonary disease, especially emphysema, often face psychological challenges, such as anxiety, hopelessness, and social isolation due to their limited physical capacity and breathlessness. The client's statement here reveals emotional despair and a perceived loss of independence rather than purely physical suffering. By responding with, "Tell me more about how you are feeling," the nurse uses an open-ended, empathetic communication technique that encourages the client to share deeper emotions such as fear or frustration. This active listening approach validates the client's feelings and strengthens the therapeutic relationship. Once the emotional state is understood, the nurse can proceed to develop teaching plans involving energy conservation, pulmonary rehabilitation, or home oxygen safety. In therapeutic communication, emotional acknowledgement always comes before education. In contrast, Option 2, there are lots of things you can still do, sounds encouraging, but actually provides false reassurance and minimizes the client's distress. It shifts attention away from the client's emotional needs. Option 3, you are just having a bad day. Today is dismissive and non-therapeutic because it belittles the client's chronic experience. Lastly, Option 4, what makes you say that? Might seem open-ended but can feel interrogative, potentially discouraging open sharing. Moving forward to a Stancoast clinical insight. Before beginning teaching or problem solving, nurses must always recognize the emotional impact of chronic illness. True empathy is the foundation of trust, because once a client feels genuinely heard, healing communication can begin. Finally, here comes the Stancoast High-Yield NCLEX Pearl. Focus area, therapeutic communication. Key principle, use open-ended, empathetic statements to invite emotional expression. Communication. Goal, validate and explore emotions before giving reassurance or education. Psychological focus, address anxiety, depression, and isolation that accompany chronic respiratory illness. Exam tip, remember, tell me more, is the classic hallmark of therapeutic, empathetic nursing communication in NCLEX-style scenarios. Let us smoothly transition to our next clinical scenario that highlights both respiratory pathophysiology and client education. As the nurse prepares the discharge plan for a client diagnosed with advanced emphysema, the client expresses concern about persistent fatigue and shortness of breath, particularly during meals. The key question here is, which discharge instruction would best help the client minimize dyspnea and conserve energy while eating? The available options are as follows. Option 1, eat simple carbohydrates for quick energy. Option 2, eat fatty foods to get maximum caloric intake. Option 3, eat frequent small meals to reduce energy use. Option 4, eat the largest meal late at night before sleep. The correct answer is Option 3, eat frequent small meals to reduce energy use. Now, let us explore the expanded rationale behind this choice. Clients with chronic obstructive pulmonary disease, especially those suffering from emphysema, experience increased work of breathing due to alveolar wall destruction, air trapping, and loss of elastic recoil. This constant respiratory effort demands more calories, but simultaneously causes exhaustion and breathlessness during even basic activities like eating. Large, heavy meals can worsen this discomfort by distending the abdomen, elevating the diaphragm, and further restricting lung expansion. Hence, recommending small, frequent meals helps meet caloric needs while preventing unnecessary fatigue and oxygen consumption. Furthermore, smaller meals are easier to digest, prevent early satiety, and promote better tolerance. Clients should be advised to rest before eating, use prescribed bronchodilators about 30 minutes before meals, and sit upright to improve breathing efficiency. This approach not only enhances comfort but also supports optimal nutritional intake, preventing the muscle wasting and unintended weight loss often seen in advanced chronic obstructive pulmonary disease. Moving on to the incorrect options, let us clarify why they are not appropriate. Option 1, which suggests eating simple carbohydrates for quick energy, may appear logical at first glance. However, these foods are metabolized rapidly and produce excess carbon dioxide as a byproduct, potentially worsening respiratory acidosis. Moreover, they lack sustained nutritional value compared to complex carbohydrates that release energy gradually. Next, option 2, recommending fatty foods for maximum caloric intake, is also misleading. Although fats are calorie-dense, excessive fat delays gastric emptying, increases early satiety, and raises the risk of hyperlipidemia. Since many clients with emphysema already face cardiovascular risks from chronic hypoxia, a balanced diet rich in complex carbohydrates and lean proteins is safer and more beneficial. Finally, option 4, which advises eating the largest meal late at night before sleep, is physiologically counterproductive. Such practice elevates oxygen demand near bedtime and increases the risk of gastroesophageal reflux when lying flat. Additionally, clients tend to have more energy during the daytime, making earlier meals a better choice to meet caloric requirements efficiently. Moving forward to a Stancoast. Clinical insight. Every bite should give strength, not shortness of breath. In emphysema care, small, frequent meals and mindful pacing transform nutrition into a respiratory support strategy. Finally, here comes the Stancoast High-Yield NCLEX Pearl. Encourage clients to consume small, frequent, high-calorie and high-protein meals to meet energy requirements without aggravating dyspnea. Offer fluids between meals instead of during them to prevent gastric distension. Instruct clients to use bronchodilators 30 minutes before meals to ease breathing. Avoid large or late-night meals to reduce reflux and improve rest. The ultimate goal is to preserve energy, optimize oxygenation, and maintain adequate nutrition, the 3 foundational pillars of chronic obstructive pulmonary disease home management.